At the outset, I thank the 35th Great Wall ICC AHS 2024 for inviting me and giving me an assignment. I extend my thanks also to the President, Professor Wang Ji Wang, and the past President, Professor Wu Yongjian, and also my friend Firdaus Misbah and the organizing committee. I give my all the success for the conference. Retrograde CTO PCI, tips and tricks. The lecture is the last, but never start the case in the fag end of the day when you are going to receive phone call from the home minister or the defense minister that where are you, why you are late. So always please start with a fresh mind, with a new day and a good early. See to that your team of Cath Lab is also fresh and nobody is in hurry and bury. I thanks and salute to my mentors, Dr. Surya Prakash Rao, Dr. Kaparthi, and Dr. Dash for sharing their insights and their in my preparation. CTO is, as we know, defined as TIMI zero antigrade flow and the duration of occlusion of more than 3 months. Historically, the first reported case of CTO done in 1990 by Khan and Hartzler via saphenous venous graft. The success rate has been steadily growing over the last 2 decades or 3 decades from 70 to 90 or 94%. A retrograde CTO PCI, successful CTO recanalization is the last frontier in PCI. The added challenge is retrograde CTO PCI and is a multiple of the last frontier to conquer. This particular slide we know very well. The various steps of CTO approach for the retrograde, but the majority of the retrograde procedures are reverse cart, and the difficulties what we face is about finding a collateral channel, channel crossing, wire crossing, connecting the space, navigation of the proximal CTO vessel, and the externalization. Before we start for the tips and tricks, we do understand that the channel identification and the type of channel and the reverse bends, continuous bends, and corkscrew type, so that our hardware is selected in such a fashion. The category of difficulty is like easy 0 score, intermediate is 1 to 2, and difficulty is more than 3. The operational angiogram should have a wide field view, long runs, avoid the panning, dual injections, and use enough time to evaluate collaterals and focus on the CTO, that is the entry, the body, and the exit. And as Dr. Michael had already said, CT angiogram prior to a retrograde attempt will be very, very helpful. CTO wires, what we need in this retrograde is the soft tip microchannel tracking hydrophilic polymer jacket wires, soft tip collateral tracking wires, penetration wires of intermediate and high tip load wires, intentional tracking wires, intermediate and high, externalization of the wires, re-entry wires of dissection and knuckle wires. The basic of retrograde CTO wires is with this soft tip microchannel tracking hydrophilic polymer jacket, that is from the Filter series, and soft tip collateral tracking wires is from the Sion, and no doubt of lately the Gaia series have taken a step forward. The wire profile for a septal entry is a small bend at the tip. A secondary bend is also useful to enter into the channels and for a reverse knuckle entry and through the entry of the stents, struts. So, simple example of septal crossing with a Xeon and with a Corsair Pro. The selection of wire is very important. Should be soft tip and gentle. Stereognosis and paying attention on to the movements is very important. A septal crossing with a Xeon blue. Even the computer has got fatigued. No, this one. Sorry for inconvenience. Okay. Yeah. It's a septal crossing with Xeon blue with Corsair and then exchange to Caravelle. As we know, Xeon is having it's a hydrophilic wire with tip loads of 0.7, 0.5 is Xeon black, and Corsair Pro of lately had helped to cross the very tortuous septals, and availability of SUO wire also quite helpful for the tortuous vessels which are of vertical bends. Why it's not working all? It should work all. Yeah. No doubt wire escalation was done. The given out examples are appears to be quite simple. Just moving, jumping without touching. See? Next. Yeah, the file load is quite heavy. SUO being used in epicardial. Okay. Now another topic which is of very interesting. It's thing like connecting spaces, like wires are too apart and or wires are not in the same plane. So avoid this by using contemporary reverse cart. Antigrade preparation should be well in mind. Try to work in a straight part of the artery. Virgin territory of wiring. End balloon wiring. Wire towards the tip of the balloon rather than from the side. Exceptional situations are contemporary reverse cart. Sometimes not possible. Like usually need a retrograde knuckle. Difficult to control where the wires go and the size of the subintimal sphere. Very long CTO, calcified vessels, prior CABGS, short CTO, but no space to work in the occlusion. I was guided, and in which space, that is sometimes in the subintima, sometimes in the lumen. Both are in the lumen, both are in subintimal spaces. So get both the wires in the subintimal, use a knuckle type, still cannot connect, use the IVAS, bigger balloon, move to somewhere else in the vessel to connect, maybe due to calcification. High pressure balloon, subintimal atherectomy, stent antegrade, and retrievable scaffold antegrade. Can't get retrograde wire subintimal, retrograde scratch and go, stiff wire with bigger curve, retrograde base, convert to ADR, use the retrograde equipment. These are the various thought process once we should get it in the mind when we are in a tough situation where our wires are not in the good position. The landmarks are not meeting. So I was in a short occlusion and in a retrograde true antegrade false. So challenges is the proximal to the occlusion is diffuse disease, proximal dissection, deliver guide extension, microcatheter getting fatigue, try to trap the retrograde wire in the antegrade wire, change the microcatheter, calcification of the vessel, and proximal vessel preparation. The microcatheter to the distal vessel, failure to cross, be ready for better or a larger guide with a guide extension, balloon, and anchoring, and new or shorter microcatheter, low profile microcatheters, balloon dilatation, anchor the retrograde wire, or check out with a new collateral where we can go ahead. I'm just rushing up because of the time. So most of the cases, what we have been doing is a conventional reverse cart where the longitudinal overlap of antegrade and retrograde wire. Balloon is over the antegrade wire to the point of overlap and inflated. The connection is created and the retrograde wire is advanced into proximal true lumen. The directed reverse cart, which we have not done much in our center, it is by antegrade preparation. The wire is advanced up to 5 to 10 millimeters proximal to the distal cap with microcatheter. A small sized balloon is advanced and inflated. The retrograde wire is advanced and directed towards the balloon catheter and gently pushed, followed by deflation, and the retrograde wire advanced with sequential dilatation of the balloon in the CTO segment, and the wire is advanced in the proximal true lumen. Whereas extended reverse cart is the proximal cap with a small side branch, and the retrograde wire is in the subintimal space with an antegrade balloon inflated, and the wire is been pushed forward towards by rotating towards the balloon. How to bypass the uncrossable and undilatable distal cap. One is like retrograde scratch and grow, retro base, retro BAM, dual lumen catheters, retrograde Carolina. Professor is here only, and antegrade distal cap with an external crush. This is one case where dual angio RCA CTO, good septal collaterals, anchor wire with the conus, ultimate bros, antegrade preparation was done. Retrograde Gaia through the CTO segment, followed by externalization, change to RG3, and overlap of the stenting was done in the RC case. Externalization of the wire with a simple wire cross from retro to the guiding, and with an guide liner stent assisted where we can do an externalization. Other technique is like to have a ping pong technique also. Oh, sorry, not ping pong, Rendua technique. That will be in the CTO segment or into the aorta and the vessel ostium. Snaring we need to pull. So the externalization has got some challenges like reverse cart perform close to the ostium. Once the wire is in the aorta, no space to pull back the wire. Ostial occlusions. Wire has knuckled into the aorta. Antegrade and retrograde wire remains in different spaces. and the microcatheter gets fatigued. Trap the wire in antegrade guide. If the tip is in, that may be of adequate. Finally, the stenting can be done as usual. So before coming out, please do check the collaterals for any injury. Channel injuries are there. Usually small leaks, they close down, but a perforation or a major leak can be given coils. In conclusion, always remember the landmarks, kissing guide wires, tracking and catching to have a proper retrograde successful CTO PCI.